At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Thank you, and welcome to Leadership and eHealth Change Management, Perspectives from Successful Hospital Leaders. The Pan-Canadian Change Management Network is pleased to present the third in a series of change management webinars. My name is Barbara McCaffrey from Alberta's Toward Optimized Practice, and I'm hosting today with my fellow Pan-Canadian Change Management Network member, Cindy Hollister from Canada Health Infoway. We're pleased to have two leaders presenting today from an Ontario hospital that has undergone significant eHealth changes. We will be hearing shortly from Dr. Jeremy Theal, Chief Medical Information Officer and Staff Gastroenterologist, and Sandy Saggar, Director of Information Technology and Clinical Informatics, both from North York General Hospital in Toronto, Ontario. The learning objectives for today's session include to identify key organizational leadership features influencing change management in organization undergoing electronic health transformation. We'll also be identifying the connection between leadership and each of the core elements of the National Change Management Framework, which include governance and leadership, stakeholder engagement, communications, workflow analysis and integration, training and education, and monitoring and evaluation. In today's webinar, before we get to the presentation from North York General Hospital, we will briefly introduce you to Canada Health Infoway, the Pan-Canadian Change Management Network, the National Change Management Framework, and to Canada's HIMSS Stage 6 hospitals. Again, to ask questions, please use the Q&A panel at the top of your WebEx screen by clicking on the drop-down arrow. Select Q&A and send your questions to all panelists. The question and answer period will begin after all the speakers have finished their presentations. Now let's go to Cindy in Toronto.
Thanks, Barbara, and both a good morning and good afternoon to those joining us from all over the country today. I'm Cindy Hollister, a nurse by background and a clinical leader with Canada Health Infoway's clinical adoption team. Canada Health Infoway, sometimes referred to as Infoway, is a federally funded, not-for-profit organization created in 2001 with a mission to foster and accelerate the development and adoption across Canada of electronic health information systems using compatible standards and communications technologies by building on existing initiatives and through collaborative relationships. The Pan-Canadian Change Management Network, supported by Canada Health Infoway's clinical adoption team, is a grassroots collaborative of change leader enthusiasts from across the country, sharing best practices and ideas since November 2009. The network facilitates a national community of practice for change management leaders involved in the implementation of electronic health solutions, providing an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns within the eHealth space across the provinces and territories. Change management working groups are formed on an as-needed basis to work on deliverables of the Pan-Canadian Change Management Network and provide national expertise, insights, and input to shape change management strategies and outputs to accelerate adoption and benefits realization of health and information communication technologies. The Pan-Canadian Change Management Network has developed an integrated framework for describing change management activities within the context of eHealth projects that consists of 6 core change management elements. The first being governance and leadership, and the mechanisms used to steer or regulate the course of a project, including how stakeholders can affect the priorities and progress of a project, as well as the change management activities occurring within a project. Stakeholder engagement is the process by which the perceptions, issues, and expectations of stakeholders are learned and managed. Stakeholder engagement includes focused attention on the individuals who are expected to change. Their behaviors and needs must be defined, understood, and considered when implementing eHealth projects. Communications is the process of providing stakeholders with what they need to know, in order to prompt appropriate responses and/or actions. And workflow analysis and integration is the process of understanding current work processes and opportunities for improvement so that new processes using e-health solutions can be sustainably embedded into the culture, as evidenced through their presence within steady-state operations. Education and training is the act of imparting both knowledge and specific skills among key stakeholders to promote adoption, and monitoring and evaluation is the process of reviewing whether change management activities took place as planned and the extent to which they were effective. So in essence, this national change management framework helps to proactively focus attention to these core and vital activities, aiming to minimize negative consequences. Thoughtful contemplation of these undertakings, both in planning and in execution, proactively considers users of e-health solutions and presents communications opportunities. It also supports the integration of technology into practice and overall supports people and their organizations as they transition from the current state to the newly desired end state. This is the goal of the National Change Management Framework. Today's focus will be particularly on leadership and its necessary requirements for enabling transformative change. You will learn more about the Health Information Management and Systems Society's EMR adoption model from our presenters today, but in the meantime, I'd just like to acquaint you with Canada's currently recognized HIMSS Stage 6 hospitals. They are South Okanagan General Hospital, an 18-bed community hospital in Oliver, BC, and in Ontario, today's featured organization, North York General Hospital, a very large community hospital in north central Toronto, and as previously featured in our first webinar last year, St. Michael's Hospital in downtown Toronto and Ontario Shores Centre for Mental Health Sciences in Whitby. And now I'm going to turn it over to our moderator, Barbara.
Thanks, Cindy, and it's my pleasure to introduce our two speakers today. We'll begin with Dr. Jeremy Theal. Dr. Theal is the Chief Medical Information Officer and Staff Gastroenterologist at North York General Hospital. Dr. Theal is the lead physician for the eCare Electronic Medical Record Enhancement Project at North York General Hospital, which has won 5 awards for innovation, quality, and safety of patient care since 2010. He was the recipient of the National Coach Community-Based Physician Leader Innovation of the Year Award in 2010 and has given more than 50 invited presentations on improvement of the quality and safety of patient care through physician use of advanced EMR systems. And with him is Sandy Saggar. Sandy Saggar is the Director of Information Technology and Clinical Informatics at North York General Hospital. His healthcare leadership has included experience in both the private and public sectors. He recently was appointed to the Board of Directors at COACH, Canada's Health Information Association. Sandy is part of a dynamic and innovative team at North York General Hospital that has won numerous awards and achieved HIMSS Stage 6 for their healthcare information technology success in delivering improved patient outcomes. Now off to you at North York.
Thank you very much. Hello, everybody. I'm Sandy Saggar, the Director of Information Technology and Clinical Informatics at North York General. Today, Jeremy and myself are going to share our eCare story and how our journey ties back into some of the core principles around change management. So some of the overall objectives of today's webinar, we're going to talk about what change management is, what it actually means to be a Stage 6 organization and its significance overall, what the key success factors and lessons learned were from our eCare project, and what the outcomes were to date of our eCare project. A little bit about our hospital. We're a community teaching hospital affiliated with the University of Toronto in a catchment area of over 400,000 people. We have 3 sites, and we've also listed our bed numbers as well as our annual volumes at the organization. So what is eCare exactly? It's really our multi-year clinical transformation project looking at advancing our electronic medical record, standardizing on evidence-based care, safe prescribing and medication administration practices, and a focus on clinical decision support. Thus far, we've had 3 phases of eCare, and our 4th phase is set to go live next month. Many of you are probably familiar with HIMSS Analytics MRAM model, and this actually tracks progress for hospital organizations on how advanced they are in their EMR implementations. And what we wanted to highlight here specifically is once you reach stage 4 or CPOE and above, you start to see a significant leap when it comes to improved patient outcomes and decreased costs. And at stage 4 or above, that's when you really start to bend the cost and quality curve. So in support of that, there was actually a study that was conducted in the United States that looked at an EMR implementation across the entire nation. And where are the savings exactly when it comes to such an EMR implementation? Well, looking at this specific graph, you'll see that 24% of the savings were actually from automation and efficiencies themselves. But the majority of the savings actually came when you looked at making better clinical decisions with supports from evidence-based care and clinical decision support. And this is something that gets overlooked and it's not well understood. But in practical terms, many of you have already probably heard the phrase that the most expensive tool used in medicine is really the doctor's pen. So looking at some of our system components, our core system components that we've deployed over the past few years, CPOE and evidence-based order sets and clinical workflows got the organization to stage 4 in the HIMSS Analytics MRAM model. Closed-loop medication administration and the electronic medical administration record, or EMR, and medication reconciliation and DPAR processes is where we achieved HIMSS stage 5. And then advanced clinical decision support pushed the organization to HIMSS level 6. Now, the eCare project is unique in Canada, and we wanted to share why it's different than many others. First, it's a Canadian deployment of CPOE where the evidence is baked into the physician workflow, and it's the first of its kind in Canada. Second, we're the first Canadian hospital to roll out closed-loop barcode medication administration in our medical, surgical, and critical care units. We're the first community teaching hospital in Canada to achieve HIMSS stage 6. And we've won 5 national awards for quality, safety, and innovation. I'm going to pass it now to Dr. Jeremy Theal.
Thanks very much, Sandy, and hello, everyone. This is Dr. Theal speaking. So when Sandy mentioned all the different components of our eCare system, you can see that many of them are considered advanced features in an electronic medical record. And so the idea of if you build it, they will come perhaps applies to the earlier stages of EMR implementation where you're implementing things that most people inherently understand will make their life easier, such as being able to find lab results online or not having to run to the X-ray department to see results of medical imaging procedures. When you get into things like CPOE, it really changes the way people practice, and in fact, that's when it's no longer a guarantee that adoption will be a result. And so you really need to look at how your organization is going to use change management principles in order to get the adoption that you're looking for. In fact, it's said that up to 30% of CPOE implementations fail. And why is that? Well, first of all, workflows change dramatically, and the ways that clinicians, and in particular physicians, have been working their entire career are completely turned upside down. And in addition, problems that may have already existed in your organizational policies, procedures, and workflows are magnified as a result of introducing CPOE. And even though those problems have been there a long time, the system is often blamed as the cause of those particular problems. In 2002, there was a famous failure of a proprietary, expensive CPOE system that cost $34 million. It was turned off as a result of physician dissatisfaction. And you may have also heard about other projects such as the UK NHS NP-FIT program, which was an ambitious program that planned to introduce an electronic medical record throughout the country for every citizen of the UK, which ballooned in cost to several billion UK pounds and eventually was discontinued. And also in New South Wales, Australia, where a centrally designed system was then attempted to be deployed amongst many different individual hospitals. And because all of these centrally designed solutions didn't take into account all the local variances in the way people practice, their expertise, different practice models, then unfortunately these failed and were not successful in the clinical adoption that was expected. So it's very important to tailor the clinical workflows that will be used in the new future state of the system to the local organization, and neither of these projects did that very well. And so this is really highlighting the importance of change management, and the definition as per Canada Health Infoway that was introduced earlier, the Pan-Canadian Change Management Network. Change management is a strategic and systematic approach that supports people and their organizations in a successful transition and adoption of electronic health solutions. The outcomes of effective change management include solution adoption by the user and the realization of benefits. Now, what's often said when people talk about change management is that people in general are just resistant to change, and it's often said specifically about physicians, and I'm allowed to say that because I am one, that sometimes we're sort of pegged as being very resistant people, and we don't want to change the way we work. But I would argue that if you make a positive change in somebody's daily life, they're often quite open to the change. And so resistance to change is not guaranteed. And I think it was best said by Dr. Brian Golden, who is here at the University of Toronto, that resistance to change is not some inviolable law of nature. Resistance to change occurs because individuals do not see the benefit of changing or a high likelihood of being able to do so successfully. So I think our challenge in introducing these advanced systems is to be able to help all the different stakeholders understand why they're going to benefit from changing to use this new system, and that they will be supported sufficiently to be able to do that successfully. The change management framework was already introduced, and we've included a copy of the diagram here for your reference. At North York General, we followed a 6-step sequence in terms of using change management principles for our eCare project. First of all, we had very clear organizational goals and a vision for our project, which Sandy outlined earlier. And we had full commitment from the board and the hospital leadership in terms of the budget and staff that we would need to make this project successful. And we made sure that the individuals in our organization were ready for a new major change in the way they work. We selected the leaders of the project and, most importantly, the clinician champions, the frontline practicing clinicians that would be the face of the project and would be the interface between frontline clinical stakeholders and the project team. We identified and tried to mitigate all the different barriers to change, and we'll talk about a few of those today. And we did our best to try to communicate and educate and really engage the frontline clinicians so that they understood the vision, goals, and plan of the project, that they would be involved in actually designing some of the content of the system that they would be using, and that we would be able to build some excitement and positive anticipation to combat all those feelings of anxiety before go live. When we actually went live, we did our best to support all the different clinical stakeholders so that they really felt comfortable with the change, that they were knowledgeable enough to use the new system, and ensured that the change would stick. In other words, that once the system was in place, it wouldn't have resistance and be turned off, but it would become the new normal. And finally, we've done our best to measure all the different outcomes from our project, to learn what those outcomes mean, and then feed that back into the project design so that we can get an iterative improvement in the way that the eCare system works. So as we go forward in this talk, the different parts of the framework that you see in the diagram here, we'll put them up in the top right of the slides so you can see what concept we're referring to as we talk about examples from our project. So the goals of our eCare project, when we talk about creating goals and vision, were first of all to improve the quality and safety of patient care. So this was not about technology or gadgets. It was not about cutting costs. It was really about providing a better experience for our patients, and that was something that our clinicians could really sign on for. We wanted to help the organization embrace a culture of evidence-based care and best practices and remove barriers from clinicians when they're trying to do the right thing. So make it the easy and path of least resistance to do the thing that's best for the patient. And finally, we wanted this to be a project where we build shared vision with our clinicians, that this is a project designed by clinicians and for clinicians, not something that was taken off the shelf by built by a vendor and a bunch of programmers who don't work clinically, but really tailored to the way our organization works. And so talking a little bit more now about some of the techniques that we used after we defined our goal and vision. The idea of clinical adoption of information technology, and I think the importance of supply and demand is really something we need to highlight. I talked briefly before about how systems that are inherently beneficial to clinicians, so the idea that when you build a lab information system where clinicians can easily find lab results or radiology results so they don't need to run all over the place to get information, that I think every clinician would be more than happy to use because it saves them time, and it's very easy for them to get the idea of that concept of saving time. But as we do these advanced projects where we're really starting to build systems that are not easy to understand and the benefits are perhaps not immediately understandable, we need to really use change management to build demand for these projects, unlike the simpler ones that were done before, because adoption is not guaranteed. And it's important to understand the stakeholders. One of the things that Infoway talks about in their framework is the idea of segmenting and analyzing the different stakeholders in your organization. So there are actually many different subgroups of stakeholders. There are hospital staff and administrators, and then amongst the clinicians, there are many different subgroups. Some are related to scopes of practice, such as pharmacy, nursing, or allied health. And then amongst physicians, there are different specialties, and each of those specialties may have different needs. In addition to this, amongst the different stakeholders, there will be different affinities to technology. If you see by the yellow graph on the right-hand side, some of the people that you will be engaging will be people who really like technology and will embrace any new system that you bring in place. So those are the innovators and early adopters. But you'll also have individuals who are the laggards, the people who really aren't comfortable with technology and would prefer not to let go of the paper processes they've been using for years. In addition to this concept, there is also the idea of the peer influence amongst the different clinician groups. There will be individuals that you'll probably already know in your own organization who tend to lead opinion amongst their colleagues. There are people who perhaps have high clinical volumes or have academic appointments, or perhaps just their personality is such that they're very strong in what they express to others. And so if you put those two concepts together in a matrix, which we have at the bottom there, there are individuals who have a high affinity to technology and also have a high influence amongst their peers. And those are the people you really want to target to be your clinician champions. But there will also be people who have a high peer influence and are the laggards who don't want to embrace new technology. Those may be your strongest resistors, but it's important not to ignore them. You actually want to give them extra attention and perhaps even hire some of them into your project so that they do become more comfortable and they can set an example for the other laggards that, hey, if I can use this new system, then you can too. So when we talk about clinician champions, they're very, very important to the project because they're going to be the interface between the project team and the frontline clinicians. And we feel it's important to hire a different person from each different scope of practice into the role of clinician champion, because a clinician champion who is a physician is going to be most effective in bringing about change amongst their physician peers, whereas if that physician went to talk to a nurse or a pharmacist group, they probably wouldn't have as much influence. It would be better to have someone from their own scope of practice speaking to them. When we talk about the roles and responsibilities of a clinical champion, it's important that they are actively practicing so that they're in the trenches doing the work with their colleagues and they're well respected. They need to understand the vision of the project and have passion for it. They should have paid protected time to do the project. This is not a volunteer role because they need to have enough time every single week to be involved in project meetings and design sessions so that they're really intimately involved with the project team and help make decisions about the design of the system. They should have accountability to the success of the project. Some people refer to that as having skin in the game. They need to be local to each implementation site. So if you have multiple sites, it is better to have clinician champions from each site because clinicians inherently have, for some reason, have a little bit of distrust for people who are from some other part of the organization geographically separated from where they work. And finally, they really need to work in partnership with all the different pieces of this project, the administrators, the informaticians, the IT department, and the clinicians. And I just wanted to mention a few things about physicians. Now, probably a number of these characteristics would also apply to other clinical stakeholders besides physicians, but people often feel that physicians are some of the most resistant to change, so that's why we decided to pick on them. And I apologize if any of these characteristics ring a little close to home for our physicians, but I figure since I am a doc, I might as well share some of these things because they are true. First of all, doctors are quite independent and they're trained throughout their career to be autonomous. So they really want to feel that they're in control, and if they feel that a change is being imposed on them, likely they're going to resist it very strongly. They want to be efficient. They want to save time so that they can move on and help the next patient. They are concerned about quality of care. They may feel that they're already doing their best already, but with proper engagement, they will begin to understand that they can still make even further improvements. They often want to have respect of their peers, and so one of the things that's important is they don't want to lose face in front of their peers. So when they're learning to use a new system, they don't want to feel that perhaps they're struggling or having difficulty, and so they need to be well supported in their training. They do care about evidence, so they want to show that if they're going to change, they want to understand what the evidence is that by putting in the effort for changing, that it will actually make a difference to patients and their practice. They're very influenced by their peers, so they want to they respect their peers and they want to hear what their peers have to say. So when we talked about peer influence before, it's really important that the hallway conversations that are going on in your organization are positive about the project because people really will be affected by their peers. They're also a little bit competitive. So if you're able to show them that perhaps they're falling behind other clinical colleagues, then sometimes that will spur them on to try a little bit harder. And we have seen this in our own organization when we compare departmental scores around things like medication reconciliation, that the ones that are falling behind, once they realize they're falling behind, they will try harder. And lastly, they like to be leaders. They like to drive change. So sometimes it's just a matter of making them think that the project was their idea in the first place, and then they're more likely to be on board. And this slide just talks a little bit about what we did with our electronic evidence-based order sets. This is a 5-stage process that we took as we developed a 350 order set library for phase 2 of our eCare project. and we used the same methodology for phase 3 and 4, and our library is now upwards of 520 order sets. What we did was we had a central team of clinicians that were partnered with informatics specialists, and this team created prototype order sets based on evidence and standardized with a template that had the same look and feel so that different order sets would all work the same way. We then took all those order sets out to every frontline practicing clinician in the organization using an electronic online review tool called ViewSpace. So nursing, allied health, lab radiology, medical imaging, as well as in step 3, all the different physicians who would have expertise on the content of a particular order set all had an opportunity to make comments and make changes in the order set. Once all of those comments were collected, we then consolidated them together to make a final version of the order set that was taken forward for approval in step 5 at our Medical Affairs Committee. This is an example of an online review session that was happening for a pancreatitis order set. The order set is on the left-hand side, and on the right-hand side you can see an ongoing conversation between different clinicians where they're discussing the various merits of the fine points of an order set so that they can all come to terms and agreement on what should be in that order set. And this was very, very helpful in change management because it helped our clinicians feel that they really were involved in the intimate design of the system and that it was not just something from St. Elsewhere, it was actually part of the way they work. When we talk about integrating workflows, this is very important when designing things like order sets as well, because a lot of your clinical processes may change as a result of introducing the CPOE system. So you need to look at the roles and responsibilities of the different clinicians in your organization and what things will start, stop, or continue in the new future state after go live. Also, you need to do some usability testing. What we did in our organization was we had a simulation room where we allowed clinicians to run various clinical scenarios through the system, and then we could observe what things they were able to do easily and what things they struggled with so that we could make some tweaks in the system to make it even easier for them before the go live. When we talk about the evidence in order sets, sometimes it can be easy if you're in a rush to do your project to just put some evidence in the order set and then hope that the clinicians will be able to actually make it happen when the order set goes live. But sometimes there isn't enough capacity in your organization to do the things that are recommended. An example that we have is when we created our stroke order set, we realized that there was a clinical guideline showing that every patient with a stroke should have a swallowing assessment within the first 24 hours of being admitted to hospital to prevent them from getting conditions such as aspiration pneumonia. Unfortunately, we didn't have sufficient clinician expertise and staffing to make that a reality. All of our swallowing assessments were done by speech-language pathologists, and we only had 1.5 full-time equivalent speech-language pathologists on staff. So if a patient came into hospital on a Friday night, they likely weren't going to get that swallowing assessment until Monday or Tuesday, which didn't meet the guidelines. And so what we decided to do was look at the literature some more, and we found a business case that showed that it was actually cost-effective to train frontline nurses to do a swallowing screening test. This wasn't as comprehensive as what a speech-language pathologist would do, but it would be enough to be able to separate the patients who were at high risk for swallowing problems versus no risk. And so the no-risk ones could be allowed to eat, and the other ones, where there was a question mark about their ability, could then be referred to the speech-language pathologist. We trained the frontline nurses that work on our 4 North stroke unit. They became dysphagia screeners, and that's what this picture is here. It's a nurse wearing the vest that she got after her training, and they're now available 24/7 to go to the emergency department to see people with stroke. And so we were able to default in our order set and order that every single patient with stroke gets nothing to eat or drink, and that every single patient gets a swallowing screening test before they're allowed to eat. So in that way, we were able to have the evidence actually grow legs and be successful at the bedside by creating capacity in our organization. We did similar things when we looked at the process of preventing venous thromboembolism or blood clots in the hospital. Other issues that arise in hospitals, such as contrast-induced nephropathy when patients go for IV CT scans, and also therapeutic drug monitoring for high-risk drugs such as digoxin and aminoglycosides. And this is an example of some clinical decision support that we built that's automated, that actually reminds clinicians that they need to consider prophylaxis against blood clots in patients who are admitted to hospital. And this has dramatically improved the ability of our organization to do this regularly. And now I'm going to pass back over to Sandy to talk about governance.
Thank you, Jeremy. As far as project governance goes, we know it's very key when we deliver these complex solutions out to our frontline staff. So this is a very complex governance structure, as you can see, but it's truly needed to deliver and organize all the tasks and resources as part of these engagements. So we had three main project focus groups. One was around medication integration. The second was around order sets and physicians. And the third was around interprofessional integration. Each of these pillars had a clinician champion as well as an executive sponsor, and that was key to make sure that we were able to move the project forward and get the buy-in that we needed. Each of the pillars is also governed by a steering committee, and again, it's a cross-section of managers and senior staff to be able to make those decisions that are cross-sectional decisions across each of the focus groups. And then a core committee, so that we had, again, a cross-section of clinicians and pharmacists that are able to make the lower level decisions that need to be in place to support the success of the system. We had an extensive communication plan. And I'm going to focus more on some of the unique things that might have been characteristic of North York General's plan. One of the things we wanted to do was make it fun. So as you can see, we had a superhero theme. These were posters that were put around all over the organization. And that was one of the concepts that we focused on, is how can we make this fun? The second thing I wanted to highlight as part of the communication plan was that we had not only senior leadership. So on one side here, we have our chief nursing officer, and on the other side, we have our former chief of medicine. But we also had frontline staff that were superheroes. So frontline nurses that were also part of the poster, so that people could see that their peers were engaged in the project, and then that can help with adoption as well. The third thing I want to highlight is how the anticipated outcomes were embedded in the messaging. So here's some information from the literature looking at how the project can help reduce medication administration errors by 40%. So citing that information and the impetus for the project is key along the lines of messaging, why are we doing this in the first place? So this was a very successful communication engagement, and we're proud of what we achieved with this plan. Going a little bit deeper into training and education for our CPOE and closed-loop medication administration engagement, especially since eCare Phase 2 was such a large deployment, we trained over 2,200 clinical staff across the organization. We had to plan accordingly and make sure we had additional trainers on staff as well as super users to assist with this large group of clinicians that had to be trained. We had to take the scope of the training for each clinical user, administrative user, physician user, and look at how much time did we need to set aside for each of these user types in terms of how much training they would need. So physicians or nurses or super users or managers, each may or may not require a different set of training and a different set of curriculum and a different set of time. So we really customized it for each clinician type. The other thing we wanted to focus on is make the availability of practicing future state workflows in a simulated environment. So we had a simulation lab set up so that clinicians like nurses could go in and see how they were going to administer medications after the system went live. So nurses could go see, well, how am I going to scan the medications and scan the patient wristband, the barcodes on the medications and the barcodes on the patient wristbands, and administer the medication, and how is that future state workflow going to look in practical terms? As well, we wanted to make sure that we set up test or practice environments or domains so that clinicians could have access on-site at the hospital or off-site remotely so that they could go into the environments and look and feel at how the system was going to work. We had a one-stop shop or a clinician portal for all reference materials, all clinical materials, and all educational materials. So if clinicians needed to know something, they know that they could go to one place and more than likely that information will be available for them. They don't have the time to go around searching for material. We wanted to make sure it was all available on the clinician portal. From a lessons learned perspective around training, we realized that we can't continue to build the system once training starts. We couldn't change the training material along the way. We had to make sure that it's important to get all of the system design and build completed before we start the training, because we can't make them both be dynamic. We had to make sure that once training starts, there was a freeze on the system, and once we trained the clinicians, we trained them one time and one time only, and then they could go back and practice and go back to the simulation room or log into the test environments and such. The other thing we had to do is make sure that we had support from clinical chiefs. It gets complex at times to try and arrange education sessions for the physician groups. They're busy, they don't have a lot of time, they may not have 4 hours to spare. How do we make sure that we get everyone trained before we go live? Because they certainly can't go out and practice after the go live if they're not trained on the new system. We had to factor in multiple styles of learning, so everyone does not learn the same way. We wanted to make sure that there's learners out there that may learn better with CBTs and other learners that may learn better when they're in an in-classroom session. So what are the multiple modalities that had to be in place for us to support these different styles of learner? And then the whole reinforce and repeat cycle. We know that we just didn't want to train them and let them go. We wanted to come back and continually update them on tips and tricks, come back around during the rounds process and make sure that physicians understood what are the changes in the system, and if they had any questions, we were there and available for them. We continually, after the go live, went back with newsletters and emails, some of their frequently asked questions. We started to package some of those things and make sure that they were released out to everybody so that we can make sure we push the information out to them versus them coming back and asking it individually. Now I'm going to pass it back to Dr. Theal to talk about quality and safety outcomes.
Thanks, Sandy. Now we'd like to talk about, in the interest of measuring and then improving on what outcomes resulted from the system, what things we've been able to understand about our system to date. We have taken some measurements, for example, at our 1-year point after the go-live of eCare Phase 2, and we were able to determine that actually within the first week and sustained after that point, we did have 100% adoption of all users of the system, including physicians. Physicians enter approximately 92 to 94% of their orders directly on the CPOE system themselves. The other few percent is due to medical directives, verbal orders, and telephone orders, which are still part of any clinical practice, even in a mature CPOE system, due to the realities of clinical practice. In the first year, we had over more than 1.7 million orders entered by physicians directly. And we had more than 42,000 evidence-based order sets activated on our patients. Given the number of inpatients we have every year, that averages out to more than 2 order sets per patient per admission. Interestingly, over 830,000 of the orders entered were generated through the evidence-based order sets, which means that almost half of all the clinical orders through the organization are being generated through evidence-based order sets, which helps to standardize care, improve safety and quality. Also interestingly, we discovered that the percentage of patients who had an evidence-based order set used on admission to hospital prior to our eCare go live was only about 37% of patients that had a diagnosis for which we had a paper order set applicable to them, but that after the go-live, almost all the patients, in fact, over 97% of patients admitted to hospital through the medicine program were getting an evidence-based order set on admission. As Sandy mentioned, we did create a clinician portal, and this was also to help with culture change, that all of the evidence-based resources would be in one place for clinicians to find easily and quickly. So that was a very big benefit that a lot of clinicians appreciated. When we look at some of our system outcomes, we discovered that there was a significant improvement in the turnaround time to administer important medications such as stat antibiotics. We know that first dose of antibiotic in a patient who is septic can actually improve their chances of survival in hospital. So we were very happy to see that there was an 83% improvement in the turnaround time for medications when we compared paper to a CPOE environment. And that's just because the orders are instantaneously transmitted to all the necessary people at once, and that really speeds up the dispensing and administration process while also increasing safety. One of the other things that improved related to medication administration was that the system was able to warn nurses if they were accidentally about to give a patient some medication that was actually meant for a different patient. And what we showed here is that in the first year alone, we had over 2,300 medication administrations that were prevented that would have been given to the wrong patient because the system warned the nurse beforehand. This is just one type of medication-related error. Of course, there are many more related to incorrect dose, incorrect route, incorrect time, etc. But this does give you an example of how the system was really able to improve medication safety. This slide talks about our rate of prophylaxis against blood clots in immobile patients in the hospital, or venous thromboembolism. This is an Accreditation Canada required organizational practice, and we really wanted to improve on this. And what we found is that back in 2007, where we didn't have a lot of focus on this particular issue, only about 17% of our medicine patients were receiving appropriate prophylaxis. We then had a thought leader on prophylaxis visit our hospital, Dr. Bill Geertz, who is one of the authors of the CHEST guidelines, internationally known. And through an education campaign as well as a paper order set, we were able to increase our rates to 65%. But that rate was not sustained because over time physicians forgot about the education that they had received to some extent, and they stopped using the paper order set regularly, and our rates fell down to 50%. After the eCare system was introduced and we had electronic evidence-based order sets related to venous thromboembolism prophylaxis, our rates increased to 84% even though it wasn't mandatory. And then subsequently we introduced that automated alert that I showed you earlier, and our rates have now increased to about 96% in the medicine program. And this, importantly, has been a sustained improvement because this number has actually been the same over the past 2 years. An article was published in the Toronto Star last December talking about the death rates around the Greater Toronto Area hospitals and how they've been improving. And this data is published by CIHI every year. North York General Hospital was identified as being the top performer in the Greater Toronto Area, and in fact the second best performer in all of Canada. And we wondered whether this had anything to do with the eCare system that we had introduced. Tim Rutledge, our CEO, felt that that was true. He said that health information technology has hardwired quality and safety into the hospital. But we wanted to see if that was really actually the truth if we looked into the numbers. So we did a retrospective chart review looking at patients admitted to our hospital either with a diagnosis of COPD exacerbation or pneumonia. We examined all the patients who had a discharge diagnosis matching these conditions over the period of January to September 2010, which was before we introduced the CPOE system, and then again the same months the following year after the eCare system was introduced. The system was introduced on October 26, 2010, so there was really only a couple of months of adaptation time there before we took our second sample of patients. Now, this data is going to be published in a clinical journal shortly, so the exact data is under embargo at this point. But what I can tell you is that when we looked at death rates adjusted for probability of death, which is a Ministry of Health term, which actually has a defined formula that corrects for things like age, comorbidities, diagnosis, admission type, and so forth, as well as correcting for critical care unit admission, that when we looked at patients who had the CPOE system for their care versus the traditional paper processes, there was a significant reduction in the death rate, and it was strongly statistically significant. And also, when we looked at whether a patient received a diagnosis-appropriate order set, so in other words, when they were admitted to hospital, did they have an order set that was for treatment of pneumonia or COPD exacerbation, or was it for some other condition or perhaps just a general order set that wasn't pertaining specifically to their care? We saw that when the correct order set was used, there was a significant reduction in death once again, which was statistically significant. But very interestingly, if the order set did not match the discharge diagnosis, there was no improvement in the death rate. So it shows that there was an independent effect using the evidence-based order sets to improve the quality and safety of patient care. And I'm going to pass back to Sandy for the last couple of slides to talk about the overall summary of success factors.
Thank you, Jeremy. So I'm going to summarize some of the success factors of the eCare project. We touched on organizational vision, cultural readiness, and commitment from the board and the senior leadership team all the way down to frontline staff. We've talked a lot about change management and the engagement and buy-in of frontline clinicians. Dr. Theal touched on the fact that local clinician champions are critical for peer-driven change, and that concept of by clinicians for clinicians, having clinicians have direct input into the design of the system, and it's really their system that we're building. Having an effective communication plan. We touched on our communication strategy and sharing the reasons and the impetus for the change, and then recognizing unique adoption characteristics for each specific area. We didn't focus on IT integration, but we actually focused on clinical integration, looking at the lens from a clinician point of view, from an evidence-based care point of view, and a workflow point of view. Making sure we had a robust and reliable technical infrastructure. If the system isn't functioning or it's slow, we knew that would impede adoption. And then, as Dr. Theal went through, looking at that continuous measurement, learning, and improvement, and seeing the outcomes front and center, and the reasons why we put the system in place, and seeing the benefits of it. So here we just wanted to touch on the fact that each of the core components of eCare is really a building block for quality improvement. Looking at CPOE and evidence-based order sets being a foundation, building on that with closed-loop medication administration, building on that with clinical decision support, and on that with outcomes measurement, it really starts to all feed into the quality improvement plan. And so the EMR and systems implementation, and for us, eCare has really become a foundation for ongoing quality improvement at the organization. And what's key to understand is each of these parts of the puzzle need nurturing and maintenance on an ongoing basis, on an operational basis. So we've talked a lot about change management at the clinician and physician level and outcomes for the patients. But these large-scale projects really start to drive organizational change at the highest levels. We also wanted to talk about national change, looking at how can we take what we've done and other organizations have done and start to look at sharing that on a national level. Northwick General Hospital had partnered with Canada Health Infoway to create the Canadian CPOE Toolkit, and it's free to join and free to share if you go to cpoe-toolkit.ca. Right now, we're working on a 500-page CPOE implementation guide, which is soon to be released. We've shared CPOE order sets. We've created 520 evidence-based order sets in the medicine, surgery, critical care, and pediatrics areas. And soon to be released maternal newborn order sets. We go live with that in October. And mental health order sets which we would be going live with next year. And a key to all of this is all hospitals can actually contribute. This is a collaboration platform for all of us to build on. During the first 8 months of having the CPOE toolkit available, we've been very successful in having 22 organizations and over 250 users join. And we've just shared some of those organizations across the nation here. Thank you very much.
Wow, thank you, Dr. Theal and Sandy, for that excellent presentation. That was outstanding. We have time for one quick question. And eCare was a multi-phase project. And as you have moved from one phase to the next in eCare, what have been some of your key lessons learned relating to change management and leadership?
I think one of the key things for us that we've learned along the way is there's no real cookbook to change management. We've highlighted a lot of the core principles when it comes to change management, but along the way within a project or going from project to project or phase to phase in our case, we've learned lessons along the way and we've tweaked our change management strategies. We've had to accommodate different areas that we're implementing in, a different set of clinicians and resistors to change. And so we've really learned that we have to adapt not only during a project, but as each phase of a project rolls out, we need to look at change management holistically.
Wonderful, thank you. As we come close to the end of the hour now, I want to let participants on the line know about some resources for change management that are available through Canada Health Infoway. If you go to the website, you can get access to the framework and toolkit for managing eHealth change. As well, there is an online toolkit repository that's available, and you can join the Pan-Canadian Change Management Network on LinkedIn. And as we finish up the hour, I certainly want to thank Dr. Theal and Sandy for a wonderful presentation. That was fantastic, and you were able to share your lessons learned to a large audience right across Canada, and it is greatly appreciated. I'd like to thank the attendees on the line and to let you know as well that once you have completed the webinar, you will be receiving a survey from Canada Health Infoway, and we would really like your feedback and be able to improve these webinars where needed. I also want to remind you that the past webinar that we did with other hospitals is available online through the Canada Health Infoway website, and this webinar has been recorded and will be also available through Canada Health Infoway. So thank you very much to all attendees for participating today, and we'll wish you a good day. And thanks again to North York General Hospital.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.